Hi, everyone. This is Gautam Nayak. I'm a cardiologist in Wenatchee at Confluence Health and governor of the Washington State ACC chapter. Thank you for taking the time out of your busy schedules to join us. As we all know, the COVID-19 pandemic has affected hundreds of thousands of patients and continues to pose a major threat, health threat internationally and in the United States. We are all facing unprecedented challenges. The American College of Cardiology has been committed to widely disseminating up-to-date information regarding COVID-19 to its members while collaborating with other medical societies and our government for the welfare of our patients and the public. If you haven't already, please check out the COVID-19 hub at acc.org, which is really a fantastic repository of real-time information for cardiovascular professionals. Please do mute your device or computer. That'll help us get through the webinar without a lot of interruptions. And if you have questions, there is a mechanism within Zoom in the chat functionality to send questions in as the talk is happening. And we'll collate those questions and try to get those out to you guys at the end of the talk later today. And we'll have a brief question and answer period at that time. Today, I'm pleased to introduce first Dr. Zhang, Dr. David Zhang, a cardiologist specializing in heart failure at CHI Franciscan in Tacoma, Washington. Dr. Zhang is the head of the inpatient heart failure service at CHI Franciscan, and he will be moderating today's webinar with me. We are also very honored to have Dr. Ning Zhao, an ICU cardiologist and associate professor of cardiology at Tongji Hospital and Medical School in Wuhan, China. Dr. Zhao has been on the front line of the coronavirus pandemic, and as a colleague and friend, he's here today to share with us his insights on the disease and the important role of the cardiovascular specialist in caring for patients with COVID-19. I'd like to turn over to Dr. Zhang to do some further introduction of his friend, Dr. Zhao.
Thank you, Dr. Nayak. I appreciate your efforts and the vision. Dr. Nayak and I put this together, this seminar very quickly, since it is a global crisis and also the crisis situation for all the healthcare workers like us. So we put this seminar quickly and hope we can all learn from our international colleagues, because at the end of the day, we had to fight this together and win this fight together, because it's a very contagious disease. No one country can say they win the fight if it's controlled by one country, because we need to get rid of this thing together. Congratulations, Dr. Nayak is our new president for Washington chapter ACC. And one thing I had to comment Dr. Nayak, right? He pronounced the Tongji and the name accurately. This is the hospital with 120 years history, tradition founded by German in 1900. So Dr. Zhao will talk about that. I know Dr. Zhao back from, I think, 13 years ago when I was at University of Chicago doing cardiology fellowship, and Dr. Zhao was a postdoctoral research scientist there. He's a physician scientist. He has a scientific attitude and truthful, and always truthful, and to research and also do the treat his patient. So now I like turn over to Dr. Zhao, and then he can start our presentation. Thank you.
Dr. Zhang, am I mute?
I just unmute you. You're okay.
Okay. Okay, thank you, Dr. Zhang, and thank you, Dr. Nayak. It's my great honor to be invited here. So my name is Ning Zhao. I'm from Tongji Hospital, Wuhan. I'm going to share my screen first. Yeah, so as you know, that the outbreak of COVID-19 now is globally infected a lot of the countries. It was first found in Wuhan in December last year, And from that time, I have been working in the front line of the, I mean, this is the battle against the COVID-19. Since that time is over 2 months. Yeah, we have some experience, but we have a lot of lessons. I would like to share that with you, and I hope it helps. So the topic I will share is the clinical characteristics and the management of COVID-19 patient. For some lessons from China. And this is my hospital, Tongji Hospital. It was founded since 1900 by a German doctor. So we have a lot of academic communications and exchanges with Germany. My hospital located in Wuhan, and we have 3 campus, and also we have over 6,000 beds in these 3 campus, and over 10,000 medical personnel working here. And we have 62 clinical departments. Also, this hospital is ranked over 10 in China. So this is the 3 branches. So these 2 branches, the San French New City campus and the Optical Valley campus, are 2 hospitals which was designated as a special hospital for the COVID-19 patient. Each one have over 1,000 beds for each campus. And this is my city. It was the epicenter of China, located in very center of China. So there are over 12 million people live here, and because it's center of China, so it's a commuter area. Because of the outbreak of COVID-19 from December last year, so my city was locked down in January 23. But since we don't have any more cases in the past weeks, so my city will be unlocked at on April 8, just next week. So far, we have over 82,000 cases in China, and unfortunately, we have 3,327 people died in this epidemic of COVID-19. Most of the cases it was found in Wuhan. Over 50,000 cases accumulated in Wuhan right now, and already caused over 2,559 patients died here. So it's actually it's a crisis. And this report was from a very early observation in China. I think it's January. Look, the age of the patient infected by the coronavirus is in any age, right? So from 15 to 65, the most of the cases in this is in this age. So somebody says that the young men or the children is not easily to be infected. That's not correct. I think people in any age can be infected by this coronavirus. And we found that the proportion of the infected people are most of male, and the female sex account for 41.9%. And the median incubation period is around 4 days. Most of the most common symptom is the fever. Around 43.8 patients have a symptom of fever, and the temperature was not so high. Most of them are range from 37 to 39. And the symptoms also including the headache and the cough, and also the sputum production, the fatigue. Because I was ever infected by this coronavirus. At that time, I have a headache and also a fever. My temperature is 38.9, so it's very typical. And this is a coexisting disorder. For our cardiologists, we are very interested in the cardiovascular coexisting disorder, like the hypertension, diabetes, and the coronary heart disease. Like the hypertension is very high. Among all of the patients, the hypertensive patient account for 50%. That means 50% of the COVID-19 patients are hypertensive. That's very interesting. When I worked in the ICU ward of COVID-19, I found that especially in the very critical ill patient of COVID-19, the proportion of hypertensive patient is much higher than 15. I don't have a very exact number of that. I think it is over 40 or 50% of patients have a hypertension. That's very interesting. And this is the complications of the COVID-19 patient, including the acute. This is ARDS and also the pneumonia. 91.1% have pneumonia, and led to a 1.4 death rate. That's a very early death rate. Now, that is around 4% in China. And these two videos showed that there's a very typical radiologic findings of this kind of pneumonia. So this is a ground glass opacity, and for both lungs, for lateral. And when we don't have enough virus test kit, we use the CT scan to differentiate the COVID-19 patient from the other kind of the pneumonia. That's very useful. And this is another summary from more cases from China. And from this summary, we can find that most of the patient aged from 30 to 80 is account 87% of the cases in this age. And most of them are mild. Mild means that the patient has a very mild symptom, just a fever, a cough, or headache, but with no pneumonia, and or very mild pneumonia. And for this kind of patient, they can cure by themselves if they have a good rest and stay home. But for those severe and critical patients, that's very dangerous. Around 20% of the patient will develop into a severe or critical type of this COVID-19. That means they have a dyspnea, or even worse, a respiratory failure. That's not good. So this is a matter of great concern for our healthcare personnel. Around among these patients, there are 3.8% medical doctors or nurses, and most of them was found in Wuhan, actually, because in the very early stage, we don't know how to protect ourselves. We don't have enough PPE at that time, as January, in the very early of January, and 14.8% cases are classified as severe or critical. Actually, more than 5. Now I think it's 12 deaths so far. So this is our raw data from my findings, my observation in the COVID-19 world. So this is because I'm a cardiologist, so I pay a lot of attention to the patient who has a cardiovascular injury. We found that the troponin I positive patient are significantly older, with higher proportion of male and more in hospital deaths. So from this table, we can see that the patient with higher troponin is much older, and most of them are male. And unfortunately, their mortality rate is much higher than those with a negative troponin I. So that means if the patient have a very significant myocardial injury, that means the outcome or the diagnosis of the patient is really bad. And this is the mortality in hospital mortality between the troponin I positive and negative groups. For this 2 week in hospital mortality, we can see that the troponin positive, this curves is much lower than the troponin negative. So that means the survival rate of the troponin I positive group is much lower. And for 1 month in hospital mortality, even worse. So for those who have a myocardial injury patient, we should pay attention to their outcomes and the diagnosis, and should take care of them very carefully. So my experience, also is the lessons for the management of the COVID-19 patient, and this is also our experience from China, is to test all of the suspected cases. We should find the source of infection, and then if we find the cases or highly suspected cases, we need to isolate them to cut off the passes of the infection. So if the patient is confirmed for the COVID-19, they should be isolated or hospitalized. And for the mild one, isolate them in a very special point or just stay at home, stay indoors very strictly. And for those moderate and severe patients, we need to hospitalize them. And for critical one, transfer them into the ICU, get a better caring. So this is a matter of concern for us. This is a protection for the medical doctors. This is the protocol we followed to before we enter the ward of COVID-19 patient and after before they came out. So we used the PPE as follows. We used the also gloves, masks, and N95 face mask. And also, if you need to do some operations bedside, you need to take the face shield. And this is a protective clothing, and it can cover everything, every skin of your body. And we usually take two gloves. I mean, one gloves and then another layer of gloves to protect your skin if you need to contact the patient. And this is the more dangerous steps when you removing this PPE, because this PPE was contagious, it is infectious. So when you take it off, remove it, be very careful. So to de-infect your gloves, to change your new gloves, and then take off the protective gloves and the protective suit. So this protocol should be very, very strictly followed by everyone before and after you enter the ward. So this is a protocol we transport the patient from the outpatient department or the field clinic to the inpatient department. And we have 3 very special areas in the fever clinic to isolate the different kind of the fever patient, and to reduce the possibility of the patient from infected to each other. And also, this is a diagnosis standard for the COVID-19 in China. The gold standard is a positive result of the virus test in the upper respiratory specimen. And some patients, the result of the virus test is negative. That doesn't mean they are not infected. We need to repeat the virus test for a couple times. In my hospital, before they was discharged, or for a patient who is highly suspected to be infected, we need to test the patient for at least twice or 3 times before we confirm that he's infected or not infected. And for those who is highly suspected cases, we need to test the chest CT scan for them. This is a very typical CT scan image for those COVID-19 patients. We can differentiate from the other kind of pneumonia. But if the patient is located in Wuhan in February or in the early of this month or March, if they have this kind of CT scan images, we can just to determine he's already infected by the coronavirus. So because in this area, there's a lot of COVID-19 patients, that means they'll be very easily to be infected. And this is clinical classification. 80% of patients are mild and moderate, and around 20% of patients are severe and critical severe. So especially for those very old patients, they are might develop into the severe and critical situation with a very high possibility. For the treatment, unfortunately, we don't have very, very specific and effective antiviral drugs for those COVID-19 patients. So the treatment of this kind of patient is just expectant. We need to get a good rest and the monitoring. And in the early stage, we use the oxygen therapy for the moderate or severe patient. And because it's China, we have a lot of traditional Chinese medicine that helps for those very mild patients in the cabin hospital, in the very small hospital contains thousands of patients there to isolate them from the other healthy patients in the society. We use the traditional Chinese medicine there. This kind of TCM helps a lot. And this is the antivirus drugs we used so far. And this is for those who use the steroid for the patient, especially in the ICU ward. The steroid used very commonly, especially for the for both lungs. For the lung lesions is very significant, and have a severe short of breath. And we know the treatment of the severe patient in the ICU includes the respiratory support, as non-invasive ventilation and invasive ventilation, and also including the steroid and immunoglobulin. We also did the blood purification for those with a very high concentration of the inflammatory cytokines and inflammatory biomarkers, like the IL-6 and TNF-alpha, like that. And we did the circulation support for the patient with a septic shock. And a very important part of my job is perform the ECMO bedside for the very severe patient. And this is a standard of the critical the diagnosis standard of the critically severe PIPE in China. So if the patient met any of the following condition, like the respiratory failure and have a shock, and combined with the other organ failure, like MODS, need to be caring in the ICU, this kind of patient is a severe or critically severe type. It accounts around 20% of the whole cases. So we did the intubation, we did the invasive ventilation for this patient. But what if the patient still have very severe hypoxemia on ventilators? That's a problem. Most of patients actually in the early stage of the outbreak of COVID-19, they died because we don't have better method to save them apart from the ventilations. So far we know that the ECMO may be another options for this kind of patient who still have very severe hypoxemia after the support of ventilators. So this is a very typical ECMO cases I did in February. This is a 50 years old patient, Mr. C, admitted on Feb 11 this year. And the chief complaint is fever for 11 days and short of breath for 2 days. They have a present medical history is the intermittent fever, and the maximum temperature is 39 and short of breath in recent 2 days. And no past medical history. He lived in Wuhan, so that means he is lived in the epidemic area. And this video showed his CT scan, very typical changes of a COVID-19 patient. That is a severe one. Bilateral lung lesions are very significant, and his coronavirus test is positive. So this is the confirmed cases. This is a lab test. Be very careful to check the lymphocyte proportion of this patient. It's very low. It's only 11.5%. This is a very important clues that indicating the patient have very bad outcomes, because this is a biomarker of the COVID-19 patient. The lymphocyte is lower, the outcome is worse. And also this patient have a very high concentration of NT-proBNP and troponin. That means this patient have a injured heart function, and the echo showed that EF is only 45%. And we give them the treatment, including the antivirus and the antibacterial, because our patient admitted to the hospital. Sometimes we need to use the intervention and the intubation. This is a ventilator-related pneumonia. That's very common in the ICU ward for most of the cases. So we use the antibacterial and antivirus for this patient. And after his admission, the hypoxemia was getting worse and worse. So he was transferred to the ICU. And we did additional treatment for this patient in ICU, including the intubation and the ventilation, and also a prone position ventilation for him. But the oxygenation index of this patient is still very, very low. It's only 95 millicuries. So that's very critical. So it's a dangerous signal for this patient. And the ABG showed that this pH is very, very low, and the PO2 is also very low. And so in this case, we need to, we don't have many choices, right? So we think this patient might need the support of ECMO. So that's what I did. We did the ECMO in Feb 18 this year, and this is the initial parameters. So I took a picture after we finished the implementation of ECMO at that time, and just a couple minutes later, the SpO2, I mean the oxygen concentration of this patient is getting much better. Before that is only 90 or 91%. After that, just a couple minutes is increased to 100. And this is the CT scan before and after the implementation of the ECMO. We removed the ECMO at Feb 27. It's just 1 day after that. We look at that after support of the ECMO for 10 days, the lung lesions getting much better. And we checked the virus for 3 times as negative. And before he was discharged, we also checked the total antibody for COVID-19 is positive. That means he get the self-protection from the virus. So this is the day we remove the ECMO date as Feb 27. Apart from the ECMO, he also received the incubation, ventilation, and CRT. That's a blood purification for over 10 days. So he survived. This is a picture I took in March 19 in the ward. This is the patient, and that's me. So we are very happy for him because that's not easy for him. Survived from such a very severe condition. So far, we have finished 5 cases, and 4 of them already winning off the ECMO, and there's still 1 is ongoing. These 5 patients and 4 are females, and 4 males and 1 females. 4 are VV ECMO and 1 VA ECMO. The average age is 55.6 years old. It's aged from 44 to 68, and the duration of the ECMO is 9.2 days. And these 5 pictures shows these 5 cases. This is number 1. Number 2 is a VA ECMO, and number 3, the last 3 cases are awake ECMO. That means they received the ECMO support without the ventilations anymore. So I think I need to thank to my patient. They are the heroes of this city because they fight against the virus with their bodies together with us. We fight the virus with our drugs, with our techniques, but they fight against the virus with their bodies. So they are the heroes of the whole city. So thank you so much, and appreciate for the help from the Chinese friends from all over the world, because in the early stage of the outbreak of COVID-19, we get a lot of help from all over the world, including some of you. So sincerely, I thank you so much and appreciate for the forgiveness from my family, because I have worked in the world for over 2 months and I haven't seen my son for over 2 months. So this is a very special period. I think the virus is a common enemy for the whole humankind, and we should hand by hand, and I mean, we need to fight against the virus together. And I know that this crisis is globally affected a lot of countries, and is also very severe in USA, in Europe, and we'll always stand with you, and we'll fight together with you. Thank you so much. Yeah, thank you, David and Dr. Nayat.
Great, thank you so much, Dr. Zhao. That was amazing. Really appreciate you taking the time to do this and giving us some of your insights. We've been getting a lot of really good questions that David and I are trying to collate a little bit. And I'll try to combine some of the questions, but feel free to send in more questions if you have them. One of the questions that keeps coming up is the role of troponin in patients with COVID-19, and really more in patients that you may not necessarily suspect an acute MI. Is there a role for troponin in that situation, and how does that help guide you clinically?
Yeah, because we are all cardiologists, right? So we are focused on the cardiovascular problem for the patient of COVID-19 in the ICU ward. That's why they invite me to join their teams. So my job is to differentiate, to find out the cardiovascular problem of this patient. So among them, I found that the troponin I was increased very significantly in some patients. Also, we check the echo, the ECG, and the
Looks like we've lost some connection there. David, do you have a sense of the value of the troponin, or what are you guys doing there in this situation as far as some of your sicker patients?
Yes, before I move into that topic, the point out the units in China is different from United States. If the troponin, we use a nanogram. We use a nanogram per ml. What you see from their slides is a nanogram per liter. So in our labs, it's less than 0.04 in normal range. In their lab, internal lab is less than 14. So you see number like 100 something, 114 something troponin elevation. That's they use less than 14 at the normal range. Pro BNP, I think that's the same. Well, you know, the truth is, the troponin elevation is quite common in any sepsis inflammation patient, right? So for the COVID-19, I think we still need to know more about the mechanism, pathology behind this troponin elevation. It is reported in China, in Europe, and we observe same thing here. But you know, I understand the ACC put a statement that you only check troponin when under certain background, when you try to rule out ACS. But you know the truth, right, Dr. Nayak and our colleague. You know, patients go through the emergency room, everybody get a troponin check already. So I think we're going to deal with this anyway. You're going to get a call about this. And so the question is that I think we need to put in the background to look at patient history, any CAD risks, and in this case, probably any known history of heart failure. I think Ning also reported this cases, they observed those patients, this is like prominent critical severe case, more look similar to a myocarditis picture that what they observed. But the therapy probably just a supportive therapy.
When you see these patients that present like this as a fulminant myocarditis picture outside of the COVID setting, it doesn't sound like you would do something typically like anticoagulation, but in one of the ACC papers, they did mention potentially the role of acute microvascular thrombosis in these patients and the role of heparin. What are your thoughts on that, even though they may look more like a myocarditis kind of picture? That was a question that a couple people raised as far as the role of heparin in these patients that may present more as a myocarditis. David, what are your thoughts there?
Yeah, before, yeah, he said, Ning said he's back on the.
He's back. Oh, Ning, are you back?
Ning is back. He heard us. Let's ask him. So, Ning,
Perfect.
can you hear us? He just texted me. Huh. He said he can hear us.
See if he gets back in. Well, I think the point about the troponin is probably a very relevant point. I think that comes up a lot in the cardiology. Looks like he can hear us. Okay. So I think the role of the troponin is definitely something that is evolving. And as you mentioned, I think the ACC's statement on this is really not to check it unless you're really suspecting an acute MI.
Right.
And David, as far as the heparin issue goes, what are your kind of thoughts on that as far as the role of heparin in these patients with kind of a myocarditis picture?
Well, so excuse me. So I talked to the topic, recent topic.
I'm back.
Yeah.
Okay.
Great. Yeah.
Did you hear the
sorry. Sorry, I was offline.
Okay.
No problem. The question that's come up, Dr. Zhao, is the role of heparin in patients that have potentially an acute myocarditis picture, or patients that have maybe a troponin was checked for various reasons. What kind of is your standard there as far as treating these patients with anticoagulation that are not on ECMO or have some other indication for anticoagulation? Looks like we lost him again.
Yeah. So I don't think we can just let's say a sepsis patient, right? I don't think we can justify anticoagulated patient without any evidence of ACS or DVT or PE, right? So, but there are reports of a elevated D dimer and reports of diagnosis of a comorbid DVT or PE for these cases. So some people talk about, prophylaxis for sure. Do we need to treat like with full dose heparin? I don't think we have answer yet unless we have evidence of ACS or DVT or PE. That's my personal opinion. So Ning, can you?
Yeah, I'm back. So
okay.
the internet is terrible today.
Yeah, sorry. I know Ning live in the hotel. So
yeah.
I forgot to mention that all the, Wuhan, all the doctor nurses, I think since like late January, they all moved to hotel. The concept that we can ask them why is that they've been in the hotel for 2 months now without seeing their family. The hotel signal is not that stable. So yeah. So the question was about sometimes do you need to heparinize those patients? Let's say maybe troponin elevation, in COVID-19 infected patient. What do you got to do? Do you got to do prophylaxis? Do you got to do full dose heparin? And what's your criteria to support your management?
Yeah. So the anticoagulation is very important for those very severe patients, especially in the ICU ward, because this kind of patient, most of them are very old, at least older than 60. Most of them are older than 60. They live in bed. They lie in bed and cannot move too much. So that's a very dangerous condition to get a VTE or PE. So this kind of situation is a very important reasons to lead to a sudden death. So I have some cases, sudden cases. I highly suspected that they suffer from PE because the anticoagulation in a very early stage, we don't use the anticoagulation very regularly. So some patient died. So after that, we draw lessons from these cases. So we use the anticoagulation, including the heparin and the low molecular weight heparin for everyone in the ICU ward. Until they have the control introduction of the anticoagulation. So I think I agree with Dr. John. I agree with Debbie that the anticoagulation is very critically important for those severe and critically severe patients.
So I'll ask the second question from our colleague here about the sensitivity of the PCR test to detect the COVID-19 virus. The reason, let's say the case you mentioned, that patient ECMO, that's a VV ECMO patient. By the way, the 5 cases clarifies the 4 VV ECMO, 1 VA ECMO, right? So VA ECMO patient already successfully weaned off. 3 of VV ECMO also weaned off. Only 1 patient still on VV ECMO running now.
Yes.
Because Ning actually, Dr. Zhao presented ECMO cases to joint ACC and Chinese cardiology section about 10 days ago for the online conference for ACC. So the sensitivity, like that patient was negative for 3 times, turned out antibody positive, right? So we don't have antibody test here yet available. So we're using PCR. How do you look at the sensitivity? If negative, then clinically you suspect, and how do you break the tie there?
That's a very good question, because some patient who is actually is infected by the coronavirus, we use the test kit, the virus test kit to detect them. It shows negative. That's, according to our experience, only 40% of the infected patient, the result is showed as positive. That means 60% of the patient cannot be detected as a real positive. That doesn't mean that the kit is not good. That's complicated because depends on a lot of factors. If you cannot take the samples, you take samples very correctly, very deep of the throat, that may increase the positive ratio. If you take samples not so properly, that will reduce the proportion. I mean the positive ratio. And yeah, that's the truth. The virus test kit, I mean, is not so accurate for half of the patient. So that's a problem. That means some patient who is actually infected cases, but you will miss them. They will return home and get another kind of the spread of this virus. That's a problem. So we did the antibody detection for all of those who is highly suspected to have an infection, but the virus test is showed a negative. For these cases, we'll do the antibody detection. And apart from the antibody detection, we also did the CT scan. Just remember, the CT scan is very useful for the differentiation of the COVID-19 patient from the other lung infection, especially when you don't have enough kit, you don't have availability of the antibody detection. So there's a combined diagnosis: the CT scan, the virus test, and the antibody test, and also including the symptom and signs of the patient. Thank you, Debbie.
Can I ask just an add-on question here? Audience can correct me if I'm wrong. Our system only test patient 1 time, right? If negative, we just assume it's negative. I think specificity is no problem. Sensitivity is all we are concerned about. Do you guys routinely test patient twice? If twice, like what's the interval? Like 24 hours apart, or do you do nasopharynx, oropharynx, or just one location? We only do nasal here, nasopharynx, or bronch. Do you guys do bronch for the ventilated patient to increase sensitivity?
Yeah, the sensitivity of the virus test is a problem. Yeah, not only in USA but also in China, especially in the early stage. For those who is highly suspected of infected cases, we did the virus test, as I said just away, and we didn't do twice for those patient, who those person, because you know, in Wuhan here is epicenter. So if the patient, if the person whose family member was confirmed as a COVID-19 patient or highly suspected COVID-19 patient, or if he has a very close contact with other confirmed cases or highly suspected cases, we all do at least one time. But if the CT scan, remember, as I said, the CT scan may be more important than virus test in the early stage of the outbreak of epidemic, because that's very easy to get it, to finish. You know, we can do a lot of CT scan just in one day for a lot of patients, and we can get the images. If you find any abnormality of the image and you suspect that this patient was infected, repeat the virus test for him. So I think that will increase the sensitivity of the diagnosis of COVID-19.
Okay, thank you.
Great. One question, Dr. Zhao, that is coming up in a number of different ways is the threshold for taking patients with positive troponins, but hemodynamically stable, so NSTEMI patients, to the cath lab. What was kind of your threshold for doing that? And maybe as a follow-up question, did you guys use or deploy any unique measures to keep the personnel, the healthcare personnel, safe, you know, in this setting? What were some of the things you guys did beyond the PPE, perhaps with scheduling and teams and shifts and things like that? So two-part question. First, what was kind of the threshold to take people to the cath lab with NSTEMI positive troponin, and how did you guys kind of keep your teams safe in that setting through the through this whole process, or how are you keeping your team safe?
Yeah, that's the matter of great concern for, especially for the interventional cardiologists. Actually, we didn't do the emergent PCI for those STEMI patients. First of all, you need to confirm that this patient is a STEMI, right? So because as I said in my slides, the increase of troponin I doesn't mean that the patient is a STEMI or acute myocardial infarction, because for the hypoxemia and also the inflammatory storm can also lead to a very high troponin I or troponin T concentration in the patient. So first step is to confirm that the patient is a real AMI patient, it's a STEMI patient. So this is the first step. Secondly, in China, we have the expert consensus for the STEMI patient with COVID-19. We prefer to use a thrombolysis instead of the PCI for the patient, because we don't have the negative pressure cath lab so far. But in my hospital, we did two cases. We did two cases of the the emergency PCI for the COVID-19 patient, because we have a lot of COVID-19 patients here. Some of them may have a coronary heart disease, and we did two. But we don't have the negative we don't have the negative pressure cath lab. We just isolate our cath lab very strictly. We close the door, the windows, and turn off the AC, and sealed all of sealed the doors without any airflow between the indoors and the outdoors. And for our medical staffs, we use a very, very strict PPE, including the protective clothing, the shoes cover, two face masks, including the N95 and surgical face mask, and also maps and the goggles, and the face shield, three gloves. So that's a very good protection for the medical staffs. But so far, I don't think PCI is a better choice for those STEMI patients, because I don't know what's the condition in USA. I don't know how many negative pressure cath lab there. But if your patient is not so emergent, like the cardiogenic shock, like that kind of situation, and you need support of ECMO or a balloon pump, so I prefer to to do the thrombolysis instead of PCI for the STEMI patient. Yeah, thank you.
So yeah, I have a question about this from audience. Also, I want to ask a question too about a STEMI patient, right? Because Wuhan, the big city, I know that, and Tongji Hospital alone has 6,000 beds. I'm sure you guys in the past 2 months, you have STEMI patient. The question one, do you follow the same protocol, do PCI and, or use the TPA? The second question, I know China is a part of the same like ACC, part of this ACC quality metrics. Do you guys still use the same metrics, daughter balloon time, this kind of thing, to collect the data, or you guys, what's your guys' decision or practice about a STEMI patient?
Yeah, the STEMI, the problem of STEMI is very, is matter of concern. Actually, in Wuhan, especially in February, we describe this kind of condition as a war state. A war state means it's kind of war against the virus. So the war state is very different, very special. We cannot follow it very strictly according to the regular rules like we did in the past, like the rules made by ACC, made by CSC. We cannot do that because so many cases come to the hospital at the same time. In just one day, we received thousands of patients, just one day. We have to take care of all of these patients. Some of them are very severe. Some of them need to intubate very immediately and to get the support of ventilation very shortly. So in that case, in that condition, yeah, I don't know how many cases in Seattle, in the state of Washington, but at that time in Wuhan, we don't have enough personnel. We don't have enough doctors, and we don't have enough PPE to protect our medical doctors. So we cannot strictly follow the rules, follow the protocols. So that's why we did the thrombolysis for the STEMI patient. For a STEMI patient, thrombolysis is also a very effective way to save them. And yeah, that's a problem. So the shortage of the medical resources is a very severe problem in the early stage of the outbreak of this epidemic. I think, yeah, I don't know whether I have answered these questions.
Yeah, I think you answered. I have a quick follow-up question to Dr. Nayak, right? The current WAACC president. So, administrators in the United States hospital will still chase or want this daughter balloon time, right? So do you think, have you heard anything from ACC about this? Should we change that metrics or, during this global or crisis against pandemic? Or should we hear our interventionals, our old colleagues' opinion to, propose this change or exemption?
Yeah, was that to me?
Yes.
Mm-hmm.
Oh, I think that's a great point. Where we are in Wenatchee, we actually give a lot of thrombolytics here because of, it's a very rural location. Patients take often more than 90 minutes to get to us. And so the door to balloon kind of falls out there. But I think that's a very relevant question. It probably needs to be discussed, through the Board of Governors, probably with folks that are involved in the NCDR and how that kind of operates. But I think that definitely is going to be something that is going to need to be addressed because I think the numbers probably for 2020 will be quite skewed in a number of different ways. I'd be curious to know, when we have a chance to get Dr. Zhao back online, what they were finding as far as their numbers of actual MIs compared to that was kind of going to be the next question, is really related to some of the numbers, which hopefully we'll get them back on and we can ask them, but what they were seeing with respect to their numbers of actual MIs in other cases in that regard, because I would be curious to know, have our numbers gone down and whatnot? Are you back on, Dr. Zhao? You hear us?
I'm not sure. Can you hear me?
Yeah, we can hear you.
Oh, good.
Can you
So
comment?
what I mean?
Can you comment a little bit about two things? Number one, the numbers of myocardial infarctions that you were seeing over the course of the last month compared to maybe what you might have traditionally seen in Wuhan. And then number two, a very interesting question is, a lot of our numbers that we have here to go off of in the United States are based on your numbers there in Wuhan. Do you feel like the number of COVID positive patients and the number of deaths reported was accurate and in line with your personal experiences? And what would you say with regards to that? Was there underreporting? Was it fairly much in line? So the two questions are, number one, what was your experience with myocardial infarction as far as numbers go? And then number two, broader question as far as the reporting of cases there as far as COVID positive and deaths related to COVID.
Yeah, thank you. So the first question is the numbers of the myocardial infarction patient I had in the past months. I worked in the ICU ward. We have 30 beds in the ICU ward for a very critically ill patient. And so far we have treated over 74, I think it's 74 patients was cared in my ICU ward. For this patient, I found 2 patients has acute myocardial infarction. Unfortunately, both of them died from the combined of AMI and COVID-19. So they died both. This is 2 in my ward. But in my whole hospital, because we need to do the consultation for the whole campus for the patient in my campus. I think we had already over 10, because there's over 828 patients in my hospital at that time, and among these patients, we have over 10 cases with a myocardial infarction during their hospitalization. So I think the proportion is not so low. So 10 cases in 828 cases. So this is the number of myocardial infarction in the past months. And second, I'm pardon, I can hear very clear about the second question. Was that?
So I can modify the question a little bit for you. You're a frontline physician, you take care of your patient just like us, put all the efforts in. So the second question, I think, a little bit sensitive, but it's a good question. There's a concern in the past few days, I would say, in the United States, a growing concern about the China, the case numbers reporting system is that underreported now. However, I would modify the basic. I think we are in early stage like Wuhan now, like you were in January, right? We lack of PPE. We don't have enough ventilators. We're really in that kind of situation. Then it's the report the kits. So it is underreporting. It is this case. Do you think that is due to you guys only test the patient with symptoms, only when they present to the hospital you test them, or do you have a community drive-through, community drive-through testing system? So my question is like that. Do you think that, and my modified question, underreported or not for new diagnosis and mortality? If that's the case, what's the possible reason for that? As a frontline physician, what do you think about it?
Yeah, that's a very good question. So, yeah, for those who has a symptom, absolutely we need to do a virus test for them. That's definitely they need to test. For those asymptomatic patients, no symptom, if they have a very close contact with the other confirmed cases or high suspect cases, we also did the virus test for them at least twice. Remember, at least twice. If they are negative, they will, symptom free. They are free. They cannot need to be very strictly isolated. So far. But if they have a very close contact with the other patient without any is not confirmed, but they have a fever, have symptoms, they need also be tested by the virus kit. I mean, if you have a contact with anybody has a symptom, you need to be tested by the virus test. I mean, this is a second kind of the patient. For those who came from overseas, from the other epidemic centers, from the other epidemic areas, who came to Wuhan, they need to be isolated for 2 weeks, and also need to receive the virus test for twice at least. I'm not sure whether the case report now is underestimated. I'm not sure about that, but so far, we have did our best to find out all of the resources of the infection. That's the first and the most important steps to stop the outbreak of the COVID-19 in my city. We suffered a lot. We know a lot of this. I mean, the characteristic of this virus. So we will try our best to stop the outbreak spread of this virus. First step, to find out them, then to isolate them, and then to treat them. That's what we did in the past months. Thank you.
So the next question, yes.
Go ahead. Yeah, go ahead, David.
So, okay. So next question is this one of our seasoned colleagues' question. How many patients in Wuhan, actually you at frontline healthcare worker, you see there, how many patients were on ventilator support at the peak of the crisis in your hospital? And what was the recovery rate for ventilator patients? I would also add not just rate and how long normally those patients on ventilator before you can successfully wean off ventilator.
Yeah, that's very important. You know, in the peak of the epidemic of COVID-19 in my city, I think that is in the middle of February. So many cases, you know, and all of the beds in ICU in my ward have the patients. So we have 30, and in the peak, among the 30 beds in my ICU ward, 27 have the intubation and invasive ventilation. That's the peak. You know, for 27 patients, 16 removed the intubation, and another 11, yeah, unfortunately they died. So that's the problem. In the early stage, a lot of patients came here, a lot more. I mean, for the very critically ill patient, at least 40% of them needed the intubation and invasive ventilation. That's a problem. If you don't have enough ventilation, if you don't have enough beds, enough ICU beds to take care of them, the mortality rate will increase sharply. So that's the problem. That's what we suffered in the early stage of the epidemic of COVID-19 in Wuhan. At that time in February, I mean, more than half of the patients in ICU ward died. So that's very miserable because they are so critical, and most of them are very old. The old patients older than 80 years old, if they infected by the COVID-19, that's very bad. Few of them can survive from this kind of infections. So be very careful about this old patient. And yeah, the ventilation maybe not helps too much for them. So that's the problem.
One question, Dr. Zhao, that has come up is just the use of face masks by the general public. I know this isn't cardiology specific, but what are your thoughts there? And that's going to be potentially something that the CDC is going to be recommending here. What's kind of your thoughts on that?
You mean the face mask?
Yes.
Okay. So if you contact the patient, absolutely you need a face mask, especially for those confirmed cases, not just the fever clinic, the patient in the fever clinic, that's different. For the ward of COVID-19 patient, absolutely you need N95 face mask, especially for those you need to did some I mean, invasive operation for patient bedside. You need very close contact with patient. N95 is very necessary, I think. But
what about the general public? People, yeah.
That's very, I mean, in China, I just say in China, everybody have a face mask. Even when they stay home, if there's 2 people there, for example, I and my wife, I don't know whether you were infected because the incubation day is around 2 weeks. You don't know whether she or he is infected already or not. We don't know. So our experience is that consider that everyone around you as a potential infected patient and protect yourself very well because we are different. We are medical staffs. We have a very high possibility to contact the infected cases. So in this case, we don't think that is overprotective. That's a regular protection. Consider everyone around you as a potential infected cases. So that's I think that can if you consider as that like that, you can protect yourself better. Thank you.
Great.
Yeah, I think that's based on also Dr. Zhao's personal experience. He told me actually way back, he actually EP cardiologist. Basically, they use everybody, as the resources to the front line to fight. And he did a procedure, right? EP ablation on a patient in January. Then after, they wear surgical mask all the time. After that, the patient told him he had a fever like 2 days ago. In 2 days, and then Dr. Zhao was sick, also was diagnosed with coronavirus. So just that's why I think, the comments also include his own personal experience. I want to ask another actually important questions because I'm sure there's many doctors and nurses here ask the same question, right? Because we're a limited staff, and if we are system overwhelmed with patients influx, right? So we need to decide who can return to work and when. So Dr. Deborah Burks, who is on the task force, she actually gave yesterday during the daily briefing, she mentioned, and she had talked to all the universities in the United States now, they're going to run ELISA test by this Saturday, then offer to all the medical staff on next week. Basically, they're going to test antibody IgG and IgM, who had positive antibody means they're safe to go to work with 99.99% chance immunity. So the question, the two, I think doctor asked good question here. One is, do you think antibody test can be used safely to determine the healthcare worker, doctor, nurse to go back to work or not? Secondly, if so, right? And do you guys use IgM or IgG? Let's say if you use IgG, do you think what kind of level IgG is enough? We can say this staff is protected, he or she can return to work in hospital.
Yeah, that's good questions. So who and when can be returned to work? that's problem. For me, yeah, because I was highly suspected to be infected by the coronavirus, because so I detected myself, and unfortunately my IgG is very low, is not so high. So I'm not sure how high, I mean, the level of the IgG is the signs of the, I mean, get the protection, get the tolerance from the virus. I'm not sure about that, but before we go back to work, I need to receive at least three tests. The first is the virus test from the swabs. Yeah, this is the first test. Secondly, we need to get a CT scan before we go back to work. CT scan to see whether you have pneumonia. And the third is the antibodies test. The antibodies most important is IgG. IgG is positive or negative. We quantified the IgG concentration, and if it is over some kind of level, and don't remember the numbers. If it's positive, yeah, combined with the result of three tests, if they are all, I mean, negative, then you can go back to work. If one of them is positive, I mean, if the virus is positive, that's absolutely you need to stay isolation, right? So if the CT scan shows that your pneumonia is still there, yeah, stay isolation. And if the IgG is negative and your other two result is negative, then I think that you're safe, that you can go back to work. So that's not a very simple question and complicated. You need to combine some tests together, yeah.
So yeah, I want to add a comment on that. Everyone probably know the current CDC guideline in the United States on March 15. Of course, we don't have antibody test as a criteria yet. Basically, they're saying anybody, you test positive and fever after 72 hours after fever, that person, healthcare worker, doctor, nurse, or APC need to return to work. Just like this, I just quote CDC guideline. Dr. Nayak, do you want to ask another question?
Yeah, let me just ask one last question. You had some interesting slides on smokers versus non-smokers. What was your sense for the outcomes there in smokers versus non-smokers? Was there a difference? And how did that all kind of evolve in your institution? And were there other kinds of social factors that you found that might have been led to different outcomes?
Yeah, for the smokers or no smokers, I personally don't have many experience about about this question. So I have a slide. Let me show that again. Yeah, smoke. The never smoke account for the 85% among the confirmed cases. That's very interesting. And the current smoker is only 12.6 around the about the cases. It's very interesting. I don't know why. I just show the cases that the non-smokers account most part of the confirmed cases. I don't know why that the non-smokers is much higher than smokers. That's really interesting.
I think it's one of those scenarios where it's the trends that you might see with small amounts of data, but an interesting trend nonetheless. That was a good question. Well, I think with that, our time is really kind of coming to a close. I really would like to thank Dr. Zhao for his wonderful presentation and educational insights. And of course, my co-moderator, Dr. Zhang, for his incredible work in helping us put this together, along with Raza Orizkai from Tacoma. Thank you guys both. Really couldn't have done it without you. I'd like to thank our chapter CEO, Liana Collins, and her hardworking team for putting on this webinar with really very short notice. And then finally, I'd like to do this more formally soon, but I would like to thank Dr. Eugene Yang in Bellevue with the University of Washington, who is my predecessor here with the Washington ACC, who's really been out in front in educating our colleagues nationally on the Washington experience with COVID-19, and who's really done so much for the chapter over the last 3 years. I really appreciate all of his hard work in this endeavor, especially at this time. And thanks to you again, everybody, for joining us, and see everybody soon. Thank you.
Thank you.
Thank you.